Hello, my name is Dr. Chris McConnell and I am a dentist based in the UK. Now, I've been providing clear aligners to my patients for over 22 years now. And one of the things I've noticed in the last few years is a slight change in the narrative of the clear aligner market. Now, you need to remember that the clear aligner market globally is massive, and there's a lot of new players coming into this market space. Now, when these players come in, they have to stand out from everybody else. So there's a lot of kind of language use of we can do things faster, we can do things cheaper, you need less aligners with us, we can provide you better outcomes. So there's a lot of kind of commercial marketing language. And in addition, what's really interesting as well is recently there's been a change in the clinician or the clinical narrative of wording as well, really where former treatment protocols are being rebranded or renamed as something new. Now, in my experience, whenever you see this sort of industry focus on speed and prices, and then you see the industry change with the narrative of the name, changing treatment protocols, or not changing, but rebranding or renaming a treatment protocol, when these two things come together, that kind of forms a little bit of a perfect storm of the suspicion of misdirection. And I think currently we are in that sphere, and there is quite a bit of misdirection in the clear aligner market, which can be very confusing for the clinicians. Now, this video is aimed at general dentists providing clear aligner therapy, and what I'm looking to do is a few years ago I did a deep dive into what is the essential facts that we need to know about clear aligner therapies, and I'm going to share this with you here. So really, to start with, we need to understand why clear aligner therapy has grown, to understand where it's going. And it's a pretty easy pathway. It's something that's been coming for years, and it's a combination of aesthetic awareness and social media. It's preferred to traditional fixed orthodontics. And with the increase in CAD/CAM designs, and the functionality has improved massively. Equally, lockdown has made people self-reflect and look at themselves on Zoom calls, and this has caused a big boost. And most importantly, as I said before, with more competition from industry, they're coming out and there's a lot more options, and they're making it easier and making it more aware in the public arena. So here we have a graph showing the trend, and as you can see, we've got the boom and the hiccup kind of post-COVID, and then the expectation is that there will be continual growth from where we are now, around 120 million up to 402 million in a few years' time. Market, mainly adults, is expected to grow by around 25% in the next 5 to 6 years. And this is really more due to companies coming into the market, better technology, and of course, printing of aligners is expected to come fairly soon, and how this will change the industry is going to be very interesting. So what are the issues as clinicians that we're facing today? I would say primarily it's options and the choice of aligner systems. Now, there's many systems out there, and each is promising different things. Don't get me wrong, I'm sure they all work, because it's a fundamental basic set of principles that you need to follow in clear aligner therapy. This is not new. However, it can be quite confusing with the companies and their narratives, as I said. And as I said earlier, with we maybe can be getting a bit misdirected or a bit blindsided by the narratives and the companies that are giving this. And to be fair, this is every company. We're getting claims such as our aligners will give you quicker results, cheaper lab bills, will have free whitening, you can have a rep for an open day support, our aligners are more comfortable, you have reduced clinical time with our aligners are more predictable, we'll give you free marketing, there's a quicker turnaround, less touch. The list goes on, right? And as I said, to be fair, again, this is not just in aligner therapy that we're seeing this is in many aspects of dentistry. I think the worst thing is when you get literature from companies claiming that a study they're showing you shows X, because we need to remember that these studies are very biased, and they're there to misdirect us into thinking that their aligner system is better. So I think we need to maybe slow down and ask the questions we're trained to ask, so we can understand how the design impacts upon tooth movement, because otherwise we're at risk of issues occurring which can lead to having patients with more revision sets, having stubborn teeth not moving, patients complaining about time and treatment, increased cost for ourselves and clinic time, increased lab bills, compromising outcomes, etc., etc. What we really want is happy patients with treatment where we can have minimal visits with the best outcome and the least stress. If we do this, everyone is happy. So let's look at a few of the questions we need to ask and a few issues which categorically will affect movement and success, such as what's the anatomy of tooth movements? Do we know how much is too much? What's our maximum torque per aligner, rotational movements that can be tolerated? What happens if we go too fast? Can we damage the PDL? Those sort of questions. We also need to be asking about aligner design and how the design impacts upon movement. What works better? What reduces the risks of remakes? What about aligner thicknesses or material types? Again, these will impact upon patient comfort and efficiency of the aligners, so we need to know about that. And we also need to ask questions about attachments and what are actually needed. What is enough, what is too many, and when do they start to become a problem? Also, very importantly, is how long do we need to wear each aligner for? What's the best time frame for efficiency, for the avoidance of remakes and for good teeth tracking? And of course, do we know our profitability? Have we actually looked at what our times and surgery overheads are? So rather than worrying about hitting targets that are set by commercial companies to achieve price reduction, is this false accounting? Are there better, more fair ways? So as you can see, there's a lot of questions that we have, and I think the easiest way to answer these is to rewind a little bit and look at core knowledge. Core knowledge is something we all need to be mindful of when doing clear aligner therapy. So let's look through this, starting with the biology of tooth movements. Now, we need to be aware of what is happening biologically and at a cellular level when the tooth is being moved, and how mechanical forces impact upon that movement. As we know, the tooth is held in place by a periodontal ligament, and it is this, along with osteoclastic activity, that primarily needs to remodel when a tooth moves. So first, let's look at the biochemical reactions and what's happening. Well, the extracellular matrix of the PDL is made up of hyaluronan, or hyaluronic acid. This acts as a cement, basically holding together the cells and fibers of the PDL. If we place this under trauma, then this triggers the release of an enzyme called hyaluronidase. Now, hyaluronidase basically hydrolyzes the hyaluronan, which chemically breaks down the periodontal ligament, creating hyaluronized tissue, which then needs to break down further to allow movement and osteogenesis. Now, importantly, the forces of orthodontic pressure must be less than the capillary blood flow, the capillary blood pressure, as the capillaries have to remain open to allow bone remodeling. If the force is too great on the compression side of the tooth, these tissues are flattened, not allowing blood flow to travel, which will lead to ischemia, which causes the death of cells such as osteoclasts, osteoblasts, fibroblasts, and therefore we get no remodeling, and you'll find the tooth will not move. Equally, if you get intrusion forces that are too high, this can disrupt the blood flow through the apical foramen and risk pulpal inflammation and necrosis. So in tooth movement, there are 4 phases. We have the initial phase where the tooth moves quickly and then stops. This is because the PDL is being stretched on one side and compressed on the other, and effectively bends the alveolar bone. Then we have the lag phase, which is where the hyalinization of the tissues occurs. The tooth now stops moving as the PDL breaks down, and at this stage we see minimal movement following the initial phase. Then we move to the post-lag phase, and this is where we see actual movements once the hyalinized tissue is resorbed, allowing bone remodeling. And then we move on to the bone remodeling, where we start to see the stability of the teeth in the new position. So the duration of the lag phase is very important, and it is dictated by the amount of pressure being put on the PDL, and was also highly dependent on the age of the person and other biological factors. As a rule of thumb, for young people under the age of 25 or very simple cases, then you may be able to get away with 1 week, but that's doubtful. If you're over 25 or moderate or complex movements, then it should be 2 weeks. So why do I say 1 week is doubtful? Well, here you can see days for each stage. The inflammatory stage, the initial stage, is 2 days. Then we move into the lag phase, and the lag phase in non-complex cases should be a minimum of 5 to 7 days. Then if it's complex or over 25, then we should be looking at 10 days duration during that lag phase. And the post lag phase is 1 day. So you can see if you're going really fast, it should be a minimum of 2 plus 5 plus 1, which is 8 days. So we need to reflect on what we're being advised by companies and by the narratives from our industry of going, actually, is a week appropriate, or are we just being put under pressure to deliver stuff faster? Slow is often best, and remember, biology is independent of marketing. So let's look at biology and facts. Then we need to consider what are the complicating factors that affect tooth movement within the lag phase to therefore dictate our time frame. And these are such things as medications, age, and root morphology. So medications is basically anything that affects osteogenesis. This can be antidepressants, immunosuppressants, non-steroidal anti-inflammatories, topical steroids, systemic steroids, antihistamines, and bisphosphonates. Now, if someone is having IV bisphosphonate treatment, do not do ortho with them. If they're having intraoral, then you can treat, but you must delay until they are not taking them. Age is also important here. If they're younger than 25, you may be able to get away with 5 days wear in the lag phase, providing there's no other complications and it's a mild case. If a person's older, then you need to increase the time. Now, this graphic is for demonstration purposes only, as is a combination of age and, remember, other complicating factors. So we could be up to 10 days in the lag phase. There are certain root morphologies we need to be aware of as well, which have increased risk of external apical root resorption, or EARR. And these are when teeth are shaped either as triangular, a pipette shape, bent, or dilacerated roots, because these surface areas of these teeth at the apical areas is smaller, and therefore the pressure per square centimetre increases, and they are more prone to resorption. In this 2011 paper, they outlined the shape issues and the impact upon resorption, pointing out that the resorption should be monitored if exceeding certain measurement factors, and then we should re-evaluate the treatment as we go through. They highlighted a resorption of 1 millimetre at 3 months increases a significant post-orthodontic resorption risk by 3. And if you see a resorption of 2 millimetres at 6 months, then you have a 15 times a risk of significant post-orthodontic resorption. So at this point, orthodontics should be stopped. Another retrospective study looked at the incidence and severity of orthodontically induced EARR, finding that 27% of those assessed exhibited resorption, with 15% being a stage 2 or 3, and the severe stage 4 was being reported in about 1 to 5% of all resorption cases. However, they highlight, as with other studies, that 7 to 12% root resorption has been observed in patients who have not had ortho. So that's what would be our kind of baseline. But the common theme here is the increased resorption risk was due to a longer duration of treatment and bigger tooth movements. They found that maxillary incisors were more prone, and especially the mandibular incisors in extraction cases were a main risk. Interestingly, they also cited research that showed those having a second orthodontic alignment exhibited less or no resorption, and they postulated therefore that a previous alignment treatment could act as a protective factor. So that's good for those who are coming in for post-orthodontic relapses, I suppose. So in summary, if the teeth have smaller apical surface areas as we've covered already, and have a prolonged treatment or excessive movements, or are a periodontal risk patient, then factor this into your treatment planning. Be more aware of potential issues and maybe have more mid-treatment assessments using good resolution OPTs or periapical radiographs. And clearly, if you're using the PAs, you need to be careful on positioning so that you're getting a continuity of position and not a false reading. So on this, we need to be mindful of our radiographic practice, and it's sensible then to look at what our indications are for that. So here we have general guidelines, all as indicated by the American Dental Association, British Orthodontic Society, ICRP, etc. And these are outlined in their guidance. Now, this is a summary. If there are any concerns, then their advice that radiographs should be done, and that is the list that is here. When great radiographs are not indicated is when they will not be diagnostically useful or in simple short treatment plans. And then they further go on to outline the type of image that needs to be taken, and it could be either OPT, periapicals, lac hefts, sectional CT scans on a small field of view. Okay, so then let's look at the mechanics of tooth movement. Now, movements can be angular, tipping around mid-root, rotational around the long axes, or linear movements. There is a maximum movement per aligner that we must obey, otherwise we put too much pressure on the PDL on the compressive side, and as we've seen, this can cause issues with angiogenesis and osteogenesis, and as such resistance to movement. So for angular movements, we want a maximum of 0.25 millimeter movement per aligner. For tipping, it's 0.2 millimeters per aligner. Rotational movements 1 degrees, linear movements 0.2 millimeters, intrusion 0.2 millimeters maximum per aligner, and extrusion 0.2 millimeters per aligner. Now, for arch expansion, this can be a little bit more tricky. We can use aligners, but we need to be mindful. Aligners are very good at tipping and not as good for bodily movements. So this will increase the risk of occlusal issues if we're not careful. As a rule of thumb, check the 6's position and do not move the premolars. Sorry, rather, if the premolars need to move past these, then you need to be considering using an arch expander. Equally, if you need to move the molars, you need to consider an arch expander. Equally also, if we're moving the premolars more than 2 millimeters buccal, then we do not get good bone remodeling, and we need to consider other options such as an arch expander. So as you can see here, we haven't exceeded that 2 millimeter expansion per side, so we can get away with aligners. If we did, then we would need to move to a arch expander. Now, an arch expander is better for the skeletal expansion, which cannot be achieved with the aligners. And if we're using this, then we need to obviously warn the patient the treatment time will be longer, and also the cost will be more. So just being informed. This is a really good paper from 2023 by Castroflorio et al., where they had a moderate cohort sample treated by different operators across different sites, and then the data was compiled at the University of Turin, so it's got good validity. They looked at the efficiency of tooth movements and what to be aware of, summarising that in this study, all teeth showed a significant difference between the planned movement and the actual one, which is quite interesting. They especially highlighted that the rounded teeth showed the worst rotational changes. So upper canines, upper laterals, lower premolars, and lower canines performed the worst. Upper canines showed the worst rotational change, losing around 40% of the predicted movement in 87% of the cases. Lower molars responded very poorly in mesiodistal movements, and they recorded almost no change at all here. Now, this could possibly be due to the fact that the more distal you go with force applications, the lighter they get. So like in fixed wire ortho, the pressure is insufficient the further distal we go, and it's similar with aligners as well. Also, what could be a problem here is that the mandible has a very thick cortical plate, and again, this could impact on osteogenesis. Upper laterals were very poor as well, and only showed 30 to 40%. They showed a 30 to 40% loss of the prescribed movement in a mesiodistal direction, and a poor performance to the buccolingual movements. The worst performers overall, though, were found to be lower canines, even with attachments. So, as you can see, the red dots highlight the caution teeth. They will move, but we need to be aware of the limitations of movement. Although, to be objective, they did do the research using Invisalign, which is a gingival scalloped aligner, and this design has been demonstrated to struggle with these types of movements. So objectively, it would be good to have further research with other design styles also. But in summary, if you're moving these teeth, then it's suggested that 14 days would be preferable to reduce the risk of needing more revision sets. Alternatively, improve the design of the aligner to impart better pressure distribution. Many papers continually cite the poor reliability as well of correcting deep bites. And here in a deep bite, we want to see the intrusion of incisors and extrusion of molars and premolars. The paper we just discussed highlighted this issue, and it's also been similarly reported by other papers such as Al-Balar, one by Charlampakis and Krieger, and so on. So if doing this, then you need to look very carefully at your aligner design and attachments, or consider conventional wire orthodontics. Conversely, correction of an open bite is also not great. However, the correction of deep bites and open bites are improving with aligner design and materials. Now, saying that, aligners can do intrusion, as I said, and the best thing to do is work by using something called the frog technique. This is where an aligner movement moves only the incisors, and then the next aligner moves the canines, and then we go back to moving the anterior, the incisors again, and then back to the canines again. And so by doing this, one aligner of canines, one aligner incisors, and so on and so forth, is a good way to help with deep bites. However, this is definitely a plus 26 aligner type of case, and it's really important that we have to be mindful of this to inform the patient, because it's pointless trying to deliver it at a fixed cost similar to easier aesthetic corrections, and generally a one price fits all attitude, which I know many people offer, is pretty crazy and difficult here for the dentist to achieve. One way to help in posterior movements is more attachments, and this way the aligner then flexes less and imparts more pressure, so you can keep more torque anteriorly. Another question really is on the design of aligner and what we can then choose and do with this. So aligner design. So we need to understand the functionality and efficiency of design and how it impacts upon tooth movement. This is a great paper by Cowley, Marr and O'Toole from 2012 looking at the extension of the aligner and the material used on the efficiency of tooth movement. Basically, they looked at three styles: scalloped, 1 millimeter straight above the gingival margin, and 2 millimeters straight above the gingival margin, reporting that the 2 millimeter above had the best efficiency as the forces were able to be distributed over the whole tooth. One of the main issues with the scalloped was found that there is an increased risk of flex anteriorly as the teeth touch posteriorly. This is where the pressure from the molar region causes vertical lifting or bowing anteriorly, and this becomes more pronounced in sequential distalization. In order to combat this, we then need more attachments or engagers or locators, whatever you want to call them. We're going to reference them all as attachments in this video. So, we place more attachments, problem solved? Well, no. It actually then gets worse, because with the more attachments in a scalloped design, there is the further issue that the aligner has to flex over the attachment. In order to do this, there's then a loss of pressure apical to the attachment, as the aligner has to flex to go over it. And this results in a significant reduction in forces in the apical third. The only forces were reported as being then on the incisal third. So to try to combat this, you then need to move the attachment more incisally and have more in numbers. In contrast, they found that the higher finish line was reported as requiring less attachments. Now, Cowley and colleagues, and to be fair, this is repeated in many other papers, report that when the finish line is 2 millimeters above the gingival level, the forces in the cervical third of the crown are maintained, and you get much better control and pressure location with this design. They found that the best results uniformly were 2 millimeters above the gingival margin when using different material types, and they looked at it with or without attachments. So universally, it was better to extend. This was further reported by L. Charlesley et al., reporting that when the aligner is active at the cervical third, then it can have better movement range, especially in translational lateral movements. With the scalloped option, the forces are more incisal, so you can only really reliably control tipping. Like Castroflorio, they also reported that there is gingival deformation in the scallop design, and as such, less torque is applied in the cervical third. Then there is the thickness of the material to consider, and this has significant effects as well as trimming line. Now, to be fair, this paper is from 2012 and materials have changed and improved. However, reliably, you need to ensure that we're around 0.6 millimeters thick in order to allow for good force transmission. And again, this what they found was with the extended version, they're getting more force transmission. Traversa et al. From this 2025 research paper recorded also that the neighbouring teeth can demonstrate from 50% compensatory reactions to a tooth being moved, which, if we're not aware of, could cause issues such as unwanted movement. They found that the molars require more intensity of forces than the canine incisor, which of course is sensible as there's a bigger surface area of the root to move. They again recommend the 2mm supragingival design to reduce this compensatory reaction as an ideal for movement predictability. So, to summarise from the literature, the best movement predictability is to have a finish line 2mm straight above the gingival margin with attachments on the premolar to prevent the anterior flex. Then 1mm straight finish margin. And what was very surprising for me was that the worst design by some margin was scalloped margins with attachments. So actually, looking at all the research, the scalloped system needs more attachments and has a higher risk of failure. This is not good, as the control of movements is then less reliable, which means you will risk requiring more revision sets, which impacts upon surgery time usage, which means a less efficient workflow, more surgery time and cost for the clinician. And importantly, let's not forget the patient, whose treatment will be extended through revision sets, therefore taking more time to complete, more visits to the dentist, which is more time off work, more travel, etc. And it goes on and on. So being objective, and as is heavily supported by the literature on this issue, we should be aspiring to look at designs which finish 2mm straight above the gingival margin, as this will mitigate the risks of all the problems I've just outlined. So then we have the eternal question of who is it, which company is it that would provide aligners that finish straight 2mm above the zenith? Well, from online research, from looking at all the products of all the companies, there's only one that states that they do this and they do it, and that's ClearCorrect from Straumann. Then we have a range of mainly lab-based aligners from ProLiner, HDL aligners, S4S, and these are customizable, so you can ask for them to be finished 2mm above the zenith. And then we have Sure Smile and Smile IE, and they finish at the gingival margin straight, up to 1mm straight. This then brings us to the very important aspect to consider, which is the aligner material and how this impacts upon our planned treatment and on patient comfort. So what are our options? Well, at the time of recording, there are two main options. One is polyethylene terephthalate glycol, or PETG, and the other is thermoformed polyurethane, or TPU. In this paper from 2021, Danielle et al. From two universities in Italy looked at the polymer characteristics in clear aligner therapy and their stability in such things as staining, water solubility, physicochemical and optical properties. So the first option is PETG. The pros are that it has high transparency, which is important for aesthetic quality. It is cost effective, easy to thermoform and cut. It's non-toxic and importantly biocompatible. The cons, however, are that it has been recorded as having a loss of degradation in force and elasticity over short periods, so is recommended more for passive trays or for aligners that have less aggressive tooth movement. However, saying that, its loss in force transmission does plateau and over time, compared to TPUs, performs better. It can stain, but not as much as TPU. Our other option is TPU. The pros for it being that it has initial high force transmission and rebounds well, so it keeps its shape. It is flexible, which depending upon the width of the material makes it more comfortable for the patient, and it also is biocompatible. However, the cons are that it becomes more unstable in force transmission over time, losing the forces required for tooth movements and aligner fit. It can, in addition, absorb water, which leads to it staining more readily, so it's less aesthetic. Okay, so let's look at the forces for each material, and the very important aspect to consider is the loss of force, or in this case stress relaxation, and how this deteriorates over time. This paper by Albertini from 2022 looked at 5 different clear aligner materials and their stress reduction. Now, it's only fair to point out that a high stress does not necessarily mean a better outcome, because remember, the stress is on the PDL. We don't want to be unnecessarily overloading the PDL. We want controlled forces for tooth movement, respecting the biology of movement. They noted that in the single layer TPU, the initial stress was much higher, followed by a reduction in stresses of 50% within the first 8 hours. They then reported there was a continuous loss of stresses in a more linear form for the following 14 days. So we can see that the single layer materials have a significant level of stress relaxation, requiring much higher initial stresses of 3 to 4 times that of the dual laminate in order to be able to impart the required stresses for that tooth movement. Now remember, we need to be looking for forces to be maintained for a period of at least 10 to 14 days to allow adequate biological response in the PDL for our lag phase, and all materials met that. Then we look at the dual laminate, which were the TPU with an outer layer of PETG. Interestingly, this group had lower force stresses initially, but the drop-off was a lot less also. The continuity of stress was better, which translates as more predictable and steady forces. Because the forces are lower than the single layer materials, there is less risk of overloading the PDL. It has also been noted in other literature that the dual laminate is more comfortable for the patient as the initial forces are much reduced. Then this paper by Salvatore et al. Looked at staining between the materials of 2 major players. One being SmartTrack, which is a single layer high performance polyurethane elastomer from Invisalign by Align Technology, and the second was Clear Quartz from Clear Correct, which is by Straumann, and is a tri-layer with an inner and outer PETG based coat polyester layer and a middle soft elastomer layer. They took each material and submersed them in different staining food and drink stuffs, including mustard, red wine, cola, tea, coffee, for 24 hours. Then assessed the staining using photoelectric colorimeter to measure the level of stain. They found that the Clear Quartz from Clear Correct, which has a PETG style outer layer, stained less than the SmartTrack material from Invisalign, as SmartTrack had a higher affinity to absorption of colouring compounds. However, it is important to be objective here. Although the research was done with the University of Applied Sciences and Arts of Northwestern Switzerland, which is an independent university, 2 of the researchers cited on this paper were affiliated and worked at the Straumann Institute in Basel, Switzerland. And of course, Straumann owns Clear Correct. But saying that, the same staining issues have also been identified by other groups not affiliated with any company, such as Simonovic et al. From the University of Zagreb and Chen Lui et al. From Sichuan University in China, who again agree with the Salvatore findings that the thermoformed PETG style outer layer material, or the Clear Correct crystal quartz, was most resistant to stain. Then the thermoformed single layer polyurethane, with printed polyurethane being the worst for stain absorption. What was interesting with this was that Simonovic looked at printed polyurethanes, which brings into question, what are the new printed materials that are coming on the market going to perform like, and should we be rushing into these or not? But the basic question still stands of staining, as the 2 materials did perform differently, and so I think we need to be mindful of this when discussing and consenting with patients about diet. In my experience, often the patient who complains about staining always alleges they have fully complied, and that can lead to uncomfortable conversations. I think it's an important discussion to be had so that any stain deterioration is owned by the patient and it's not something that's complained about to us, the dentist. Then we have attachments. Now, depending which system you use, you may know these by the word engagers or locators. For ease, in this video, we're going to call these and just reference them as attachments. Now, to understand our options better, we need to know what works, what does not work, what our options are, and how we can implement them. This is a huge topic and one that should be well understood by the clinician. It's way beyond the scope of this video, and I would encourage you to research and learn these options for yourself. For an unbiased reference, this is a great book, and some of the authors of this book we have already looked at in our literature reviews as well within this video. This can be bought online. So as we've seen, attachments are useful for improving tooth movements and retention. They give something for the aligner to grip onto and allow force distribution for correct tooth movement. Here are the pros and cons. In short, you'll hear a lot about conventional or customized attachments, which are your classic attachments, and optimized attachments, which are AI placed based upon hundreds and thousands of previous setups or ClinChecks. This is a good paper from 2024 outlining attachments, options, and outcomes. Now, Demir covers conventional attachments first, which are the classic attachments and can vary in size and depth. They can be ellipsoidal, rectangular, or beveled, and are positioned to allow for force to be applied in a particular direction. Depending where these are placed and whether in the vertical or horizontal plane, they will dictate force transmission and hence tooth movement. Then there are customized, which are often smaller than conventional and are shaped depending upon specific movement required. These can be placed by an operator or with using your modeling software. Then we have what has been coined as optimized attachments. Now, these are attachments and a technology that has been developed by Align, which uses AI to place them in positions deemed required by AI from many tens of thousands of previous scanned cases. They are also called smart force attachments, which, if you do an online search, are the umbrella term for the tooth-colored bump or attachments that help Invisalign aligners move teeth, while optimized attachments refer to a specific type within the smart force family. Okay, now, do you remember I said earlier about being wary when traditional techniques start to have different names or are being renamed? This is a classic example. I mean, here we have attachments now being referred to as smart force attachments or optimized attachments. This is classic misdirection and is marketing to make a product sound better than the competitors because it sounds new or interesting. The reality is it is an attachment. So this kind of misdirection prompted me to look a little bit more into Invisalign claims, and I found this on their website, that their system is the only system in the world with features such as bite ramps, precision cuts, and power ridges. Really? I think you'll find that all aligners do these because that's a core part of aligner therapy. Now, I know other systems do this. However, to be objective, I did a very quick online search and found evidence from Spark, ClearCorrect, and Sure Smile that they all do these. Now, I stopped at this point because it's kind of, they all do them. So again, the language is very misleading and again compounds my point about misdirection being the root problem of misinformation. But coming back to the optimized attachments, my feeling is that this is classic marketing misinformation. But let's look at what the research says. Well, looking at several papers made up of various sized blind randomly controlled trials, literature research and retrospective cohort studies which were comparing conventional and optimized attachments, there's fairly general agreement that there is no significant difference between the two. There is, however, mention of optimized being slightly better at lateral incisor rotation and conventional being better in extrusion, mesiodistal angulation and torque. So basically conventional being better in almost all movements on all teeth. So in all the literature, the main one theme is that the clinical advantage of optimized algorithms over well-placed conventional attachments is not uniformly proven. So the take-home message from this is, yes, AI is cool, however, don't be misdirected by language and marketing language from companies who are claiming that because they're using AI, they can rebrand, rename a technique that is effectively what the old technique is. And as I said before, this is classic misinformation, and we need to be very, very cautious of this. And I'm saying this to the reps out there who are just selling and pretending something is more than what it is. There are so many other factors in play, as we have seen, which also impact upon tooth movement. And what about attachment materials? Well, this for me is as important as where the attachment is. Poor material choice will lead to loss of shape, poor fitting aligners, reduction in force transmission, and loss or debonding. So what are our choices? We have anterior composite. Here it's recommended to use a nanohybrid high viscosity composite, which has a high filler ratio, so it can be harder to pack, leaving voids, or having excess, which can cause the attachment to be more proud than it needs to be. However, it keeps its shape very well, and if packed properly, maintains the sharp edges required for engagement, which means good retention, if not over or underfilled, and good aesthetics. It doesn't wear as the aligners come in and out, and is good for high force transmission and bond strength to the tooth. Then we have flowable, which has less filler content and can flow into the attachment shape well. However, if larger attachments, then you get more polymerization shrinkage. Because of the lower filler volume, we get more wear and potential retention issues. They are better in areas of low stress. Now, the high filler flow is better, as with higher filler content, it doesn't wear as much as flow, but again, you can still have voids with air bubbles. It's easy to place, but can have excess flash if overloaded, which, like the anterior composite, can create issues. Like the flow though, its bond strength to tooth is weaker, and it can still round off as the aligners come in and out, wearing it away. Then we have the bulk fill composite, and this has been shown to be useful as has a high affinity of bond to the tooth. It's good at force transmission and holds its shape. The aesthetics, however, are not great. So, in summary, a high filler. This is because the edges are sharper, allowing better engagement and force application, and then don't wear, and are well bonded. Is the one of choice. Is the filler of choice. And a common misconception, and I've seen this on social media posts: should I etch and bond? Yeah, absolutely. So I don't know why people even ask that question, but they do. So yes, please. Now, IPR is also an important step to consider, and we need to be mindful of a few things here. Now, IPR must never exceed more than 50% of the interproximal enamel, and it's generally accepted that 0.2 to 0.5 millimeter per surface is acceptable depending where you are. So obviously 0.2 is incisively, 0.5 when you're going to the molars. So by reducing both contact surfaces the same amount would be the maximum of 0.5 millimeters for anteriors and 1 millimeter for molars. As a general rule of thumb though, 0.3 millimeters per contact for incisors, moving to 0.5 millimeter per contact in the premolars and molars is acceptable. So what are our options for providing IPR? Right, well, we have IPR strips. These are manual metal strips with diamond coated surfaces and are graded in thickness. The advantages are they are conservative, they have good finishing and can be used for small amounts of reduction. However, it can be time consuming and sometimes quite uncomfortable for the patient. Note must be taken though when using these to ensure that the tooth being reduced is not flexing into the adjacent space. So let's say we've done IPR of 0.3 millimeters on the mesial aspect of the canine, and we're doing IPR on the distal of the canine now. Then we need to make sure that the distal contact, say if you're doing 0.5 millimeters here, if we start to have pressure in this distal space, the tooth will, through pressure, will shift mesially into the 0.3 millimeter space we've just made, meaning that although we think we may have done 0.5 millimeters, when we come out, the tooth rebounds back 0.3 millimeters, and actually we've only prepared 0.2 millimeters. To prevent this issue, it's sensible to always put a wedge of the size of the IPR performed into the area that has the prepared space. This way the tooth does not flex and you get more true IPR preparation. For another option is rotary discs. These are great, but caution if you are new to them. They are fast and as cut in straight lines are ideal for easy to access areas such as the incisors. Caution must be taken though on using a soft tissue guard because it's easy to lacerate the soft tissue. If there's a slip, a patient moves, it might hit the tongue, lips, etc. If it's not a straight line cut, then you need to be careful because if you angle it incorrectly, you can cut into the tooth, and it's suggested that this is used by experienced clinicians. Then we have oscillating or reciprocating IPR, and this is where we have a predominantly diamond-coated file or disc in a reciprocating handpiece. This can include fittings such as a file or an OS disc. OS stands for oscillating segment. These can be dual cut or single surface cut. Because of the single cut, personally I prefer the single cut because I feel I have more control on these. The cons, however, are that they are more expensive, and when you start before it engages interproximally, or if you've angled it incorrectly, it can quite aggressively bounce or feel like quite heavy vibrations on the tooth, and the patient will tell you. So you do need to warn before you do this, and again have a little bit of practice. Then finally we have fast handpiece burrs, ideally tungsten carbide, as this will gouge less than diamond, and these are better when we need large amounts of enamel reduction or in areas where other techniques are difficult to get to. They do, however, require finishing with an IPR strip afterwards, as commonly they leave quite a rough surface. So this is an interesting paper from Brisbane Dental School, and they were looking at the amount of IPR achieved from that planned. They looked at 10 orthodontic practices with a combined selection of 247 cases, which meant a total of 2,474 planned IPR teeth. So a moderately large sample, and the data was analysed by independent clinicians. So this paper has a moderately high reliability. They found that overwhelmingly the IPR was not completed as planned, with the best IPR being registered at 75% success of the planned versus actual IPR, and the least being just under 10% of that planned. The final outcome was that the total IPR over nearly 2,500 surfaces was averaged at needing 0.2 millimeters, but the actual was 0.13 millimeters. So an average of 44% of the volume required to that of planned was achieved. Now, we have to remember also that these were orthodontists being assessed. So in theory, you could say that it might be higher with GDPs. So this is a real area of issue and has been further backed up by multiple studies, again finding IPR shortfalls of similar amounts. Remember earlier we were discussing about wedging the opposing surfaces? Maybe this is why we need to consider this flexure when we are reducing. So how can we ensure the right amount of IPR? Well, it's good to get into the habit of using IPR gauges. These are small metal finger guides. They're of certain widths, and when putting them into proximally, you will be able to tell if you've prepped too much or too little. Based upon how it feels, it will either engage and stick, or it will be loose, or you won't get it in at all. Okay, so wear time per aligner. Do you remember the lag phase we discussed earlier, where we had 2 days at the initial inflammatory stage, 5 to 7 days lag for non-complex, and 10 days for complex, with 1 day for post-lag? This is also independent. This is also dependent, as we said, with the other factors. So as a rule of thumb, really we're indicating 13 days for most people over the age of 25. Again, if we come back to the Castroflorio paper, where they were looking at planned tooth movements versus actual movements, from their discussion, they outlined that in mild to moderate cases, in general, changing the aligner every 14 days will reduce the level of correction by 12%. They also found that there was no significant difference in 10 days to 7 days, instead again preferring 14 days as recommended. So basically, in mild to moderate cases, 14 days, which begs the question in more severe cases should be at least 14 days also. But also to take into consideration is the wear times of patient compliance, and this is a massive issue. We've all had those patients who come in with tracking issues and have really super clean aligners, claiming they were wearing them for 22 hours a day, and have had this set in for at least 2 weeks plus. For clear aligner therapy, it's probably 80% compliance and 20% poor design. So a published thesis by Smosis from 2014 from University of Bern in Switzerland looked at 2 groups over a 6-month period, where one group wore aligners prescribed at 14 hours a day, and a second group were given retainers to wear at 8 hours a day. They found there was insufficient compliance for wear in the suggested 14-hour per day alignment phase, with only 62% complying. They found that for retention of an 8-hour per day requirement, there was high compliance. Now, this was a small cohort study of only 45 patients, so it has low validity. However, similar results have also been found, such as with this large cohort study, over 2,500 patients. It was done by Plus Dental, who are a large orthodontic group in Berlin, and they looked retrospectively at patients who had undergone clear aligner therapy and had used a mobile app for reporting and recording movement to the clinic. From their results, they found that 36% were fully compliant, 38% fairly compliant, and 26% poorly compliant. Okay, but what does this actually mean? Okay, as a side finding, they noticed that males who made 25% of the cohort were on the whole more compliant, and those who were having ortho for the first time also more compliant. What was more alarming, and equally also very interesting through the breakdown of the groups, was this. Now remember, they were asked to wear 22 hours a day. The full compliance obviously achieved this. The fair are those who wore the aligners within the 50 to 100% bracket, so 11 to 22 hours a day. And the poor compliance bracket are those that wore the aligners for less than 50% of the time. So that's from 0 to 11 hours per day. And what is most alarming is that the compliance was recorded as 17.7%, wearing less than 6 hours a day. I mean, what? That's crazy. So the other question we need to ask is, why are people not compliant? What are the reasons? Is there anything we can do to make things better? Well, this paper, although a small cohort and single site, highlights one of the bigger issues that's reported widely, and that of pain on initial wearing of the aligner. It's commonly accepted, and as we saw earlier, that there are much higher forces with a new aligner. So if the material is causing pain or our movements per aligner are too great, we will get pain. This is to be expected. And I think this is something we need to be sympathetic with our patients on, as it can be a real problem. Okay, so retainers. This is very important to look at, and there are different types. So what are our options? Well, the first one we have is the Essex retainer. This is the normal go-to style of retainer. It's a thermoplastic polyurethane vacuum formed retainer. The advantages are it's very comfortable, it's aesthetic, it's cheap, and it's effective. However, the disadvantages are that it can crack, it can warp with heat. You need to replace more often, maybe every year or two, depending if they're Bruxist. Obviously, it'll be a little bit more. Then we have fixed retainers, which are stainless steel wire, or in some cases can be fiber reinforced composite material. These are placed lingually and on the canine, from the canines to incisors, cross incisors. The advantages are they do not rely on patient to comply, as they're on 24/7, and they should always be used in anterior rotation, diastema and proclination cases. The disadvantage, however, are that they need to have excellent OH, so we need to keep a close eye on that. Maybe come and see the hygienist a little bit more. I suppose that's not really a bad thing though, but on the whole there is strong evidence to suggest that fixed retention is superior to removable only. Then we have the Hawley retainers. Now these have a labial bow and clasps on the first molars. They're very reliable and they're great in Bruxist. However, they are not as good at anterior control and are not very well tolerated by patients. So although there's no single option that's better than the other, they all have their pros and cons. The general agreed evidence based upon research is that for 90% of cases, a combined fixed retention with removable retainers is ideal. There are, of course, some higher risk treatments, and as outlined by the American Association of Orthodontists, British Orthodontic Society, and again from Cochrane reviews, these are the areas that we have higher risks of relapse. Now, what's really interesting here is that clear aligner cases are in this as well. The reason that clear aligner cases here is because the majority of movements in clear aligners are tipping, rotation and expansion, which are all higher relapse movements. So we need to be very mindful of this and have adequate retention, building this into our plan, hence the combination of the wire and the Essex retainer. Now, importantly, we also need to remember profitability, because if we don't know how to price properly, we're ending up doing it for free, which is not really the idea of the game. Now, there are a multitude of different ways of how to price. Lots of different companies have different ways of pricing. They have different deals. They can lock you in. You can buy ahead of time. So there's many different options, and these vary wildly. So what I would encourage you to do is to have a little look. I'm just doing this as an example here to show you a grid that you should be filling in. So the first top line, you want to fill in your costs. So what does it do for your setup, your ClinCheck fees cost? What's the case fee? So that's your lab bill. Do you have to pay for revisions? So I've made a case up here where the case fee was £1,400. I didn't need to pay anything for revisions. My retainers were not included, so I had to buy them at 300, and the other 300 there is because I wanted to do a fixed lingual retention as well. So my total is £2,000. Now, let's say I get able to access a 10% discount. In this case, that 10% discount will come off my case fee for the aligners and the retainers, obviously not off the wire retention, because I'm using a different lab for that. So here I'm making a saving of £170. Now, what I would encourage you to do is to do this cost comparison over the last 20 cases that you have invoiced or been invoiced. This way you can see the actual costs rather than perceived costs. Now, I think this is one of the things that we need to look at here, and I have to say I'm not a big fan of massive discounts that you can only access if you use lots of the product, or having imposed targets to hit to maintain those discounts. I think this is very manipulative and forces us as clinicians into having to make choices that are financial or reward based rather than what's best for the patient. Also, it artificially locks you into having to use a particular system. And as we all know, there are good and bad options with everything in dentistry, and I believe in a truly open market. So this is the kind of anything that's a time-sensitive target system that locks you in, I think is a little bit unethical. Now, I believe that if a company also can discount by up to 60% of their initial pricing, this is just wrong. It doesn't matter who you are. You could be selling sofas, televisions, or aligners. If you can discount that heavily, you're taking the mickey, and in my book that's offensive. Let's just be open and honest. Give us the prices that are the best price it takes you to deliver the product so we can work with it. Please don't penalise the clinic that is only doing 5 cases a year. This is unfair. If anything, give incentives such as buy 3 get 1 free. Then this way there's not a continual pressure to meet artificial targets set by a company. Now, I'm really big on efficiencies, and target-driven dentistry is only good for the person setting the targets. Of course, you need to choose what's right for you, but never ever feel pressured by a rep into doing more to hit the next discount level. That is just wrong. So once we have our costs, we're then that we've worked out our actual costs, we need to figure out our time costs and know in order to work out what our overheads are. So let's say we have these times here, and I've just penciled in again just a generic average, but I encourage you to put in what you do. However, when we have this is sort of a little bit generic, but this isn't actual, because remember, we may have extra revision sets, extra reviews. How do we measure our time? Well, again, what I would suggest you do is go back and look at your last 20 cases and figure out all the clinical time used. So here I'll show you my real-time clinical use for my last 20 cases. So as you can see, I predicted that I was going to use 4¼ hours. So if I put that in, this is what I get. As you can see, 11 of my 20 were over my predicted threshold. But this is clinical time. Remember, we need to add non-clinical time, such as doing your 2D smile design, doing your setup, doing your ClinChecks, doing your consents. So by the time we build all this in, I'm adding this time back on. This is what I get. So now nearly 75% of my cases are over my allocated time. So what does this mean? it means that my guess time at the beginning was wrong, and my actual time should be 5.5 to 7 hours. So I can obviously offset the overcooked ones with the undercooked ones in green. That's a bit of give and take. I get that. However, what I learn is that actually my predicted timings were way off the mark, and actually I was being inefficient and I was not making any profit here at all. So if we come back to our costings on hours that we spent, then we get this. And as you can see, these are my hourly rates and lab cost combined. Well, we saw that if I changed my 4-hour rate but took 7 hours, I'm making a physical real-time loss of £900. Okay, so remember, you also must build in lag time. So this is FTAs, this is late cancels, this is revisions, etc. I would suggest a minimum of 10% should be added. So now my real-time loss has jumped up to nearly £1,000 here because between my predicted and actual figures, because I haven't built in those unexpected issues. As I said, this is an exercise I would encourage you to do and maybe repeat every year to check that you are doing the right amount and you're not overcooking or penalizing yourself, as I have indicated in this scenario here, where looking at my real times, my figures were drastically out. Okay, so how can we trim the fat? First of all, get your nurse involved, right? They want to be involved. Train them to scan, take photos. If they're radiographically trained, they can do OPTs, and they can all upload these items onto your portal ready for you to complete your prescription. What about if we get the patient to do their own reviews maybe? Well, there's a system called Dental Monitoring, which is quite good at this. The patient's given a box that they attach with their phone and records at home. This is then uploaded onto a site and one of your other team members can monitor. What about using your therapist to remove engagers or fit whitening and do hygiene throughout? There is talk while at the time of recording this video that there may be an orthodontic therapist session where they opportunity where they can actually put engagers on, so that may be coming also. And remember, at the end of it, your therapist or nurse again can scan for retainers and submit this to the portal to get your retainers made. So if we reapply these and come back to our timesheets, remember that we did that in the last just earlier. I've now got my predicted time down to 2.25 hours. But remember, I still need to put this through a 20 patient real-time analysis. So this is just my way of trimming the fat, allowing me to be more competitive in my pricing. Okay, so in summary, what have we picked up? What's the take-home messages from that we've looked at here from the research? Well, before we start, we need to consider arch expansion, right? Is the movements that we're going to do, are they going to exceed what the aligner can achieve? Do we need to look at a separate arch expansion option? So that's important to start with. Look also medical complications and do not provide if we have any interfering medical complications, or at least we need to warn the patients of the risk that there will be delayed movements, that they're going to have to wear their aligners for longer, that they may have revision sets based upon their medical complications. Remember, we need to get the patient to own their own problems. Be very cautious on deep bite cases. So either we can address these using the frog technique like we've looked at earlier. So if we're going to do that, that's going to slow the aligners down. So we need to charge properly for this or refer out. And equally with open bite cases, again, same principle. We either need to charge properly because you're going to be talking 26 plus aligners, or refer out to get done. When we're planning, all the literature categorically is pointing towards a 2mm straight finish above the zenith. So a 2mm straight extended aligner is what we really should be aspiring to here, for all the reasons that we saw earlier of force distribution, of reliability of control of tooth movements across multiple teeth to prevent flexing anteriorly, etc., etc. For patient comfort as well, we saw that the dual laminate was better because there was less stress force initially, which meant that patients could tolerate it better, and it maintained its stress forces better for the 14-day period. We want maximum movements of 0.25 millimeters or 2 degrees per aligner. And we want to limit the attachments, because remember, with the attachments, when our aligner went over the attachments, there was flex here, and if there's too much flexing, you're not getting any pressure. If you're using a scallop design, which you shouldn't be, as we just discussed, you're not going to have enough pressure on the apical third. Very importantly, not having excessively long treatments, or if we do, then we need to reduce the forces on each aligner to reduce the root resorption risk. Also, when treating, we want to, we're placing the attachments, etch and bond, and nanohybrid anterior composites are best because they maintain the sharp edges, which they don't wear as the aligners come in and out, which means we have more predictable forces that are on the attachments throughout, which means more predictable tooth movements. And then for IPR, we want to look at using either reciprocating discs, and remember to wedge the opposing side when you're doing this, and also to use the IPR gauges to make sure that we have removed the correct amount of IPR. And remember, it was quite amazing that 56% of orthodontists in the study we looked at did not achieve, 56% of the overall IPR done was not satisfactorily done in the study we looked at. Also, with the loss, we get about a 50% stress loss within the first 8 hours. So maybe an idea here is to advise patients to change their aligner before going to bed, because we want to get a maximum wear time from first fit. We don't want them maybe putting the first aligner in the morning when they're going to take it out maybe for a coffee or a biscuit, take it out for lunch, take it out for dinner, etc., etc. So we're being able to impart the maximum efficiency of that aligner to the patient at the right time. So putting in maybe before going to bed would be a good idea. When seating the aligner, always use a chewy so that the attachments are engaged. And as we saw, wearing for 14 days per aligner is pretty much paramount. You could get down to 10 days if you are kind of really a young person with mild aesthetic movements and you're pretty sure that they are going to be really compliant. So we just need to make sure that they wear that. But remember, we saw that paper where 17% of patients wore the aligner for less than 6 hours a day. All right, that is quite shocking. So I think that shows us, and I think that should really give us the support that when somebody comes in and says, "Hey, my teeth aren't moving, and I've been wearing it all the time." 1 in 5 of your patients will not be complying by wearing it for 6 hours or less a day. So I think you can have a little bit more confidence in challenging those 1 in 5, and you probably know who they are. We also then need to look at maybe using a monitoring software that will help us and help the patient engage in the process, therefore hopefully making them wear the aligner more. But as we saw, the study didn't make them wear it better. They just saw how much they were not wearing it. And then obviously monitor closely the higher risk people, the ones you've identified as having short roots or ankylosed teeth, etc. at the start. Then importantly at the end, we've seen the evidence points at retention with a fixed and removable retainer. And ensuring that the patient knows they need to replace the Essex every 12 months at a minimum, or when they kind of wear through it. So I think at least if you consent for this, they'll be aware. And then importantly, maintaining hygiene for for 3 monthly hygiene for the first year, so we can keep an eye on a retainer wear, whether it's cracking, wearing away, OH, and all the rest of it. So it allows us a better control and management of that patient. I hope you got a little bit from this video. It's been quite quick paced, and thank you for staying. If there's anything you want to go back over and have a look at, then please do. This is the Real Dentist site. You're on it already. You can now download your CPD certificate, and please have a look at our other videos and help sections and see what's helped. We're there to help you, the clinician, in looking at real dentistry.